Welcome to this video. In this video what we're going to talk about is the topic of cardiac arrhythmias, which is a really clinically important topic to understand. This video is going to be split into a huge number of different parts, and all of the parts will be in the playlist on the cardiovascular system. So if you're looking for the next part of the video and you can't find it, go to the playlist on the cardiovascular system and all of the parts will be there. Okay, so what I'm going to begin with then is the definition of a cardiac arrhythmia. What is a cardiac arrhythmia? So a cardiac arrhythmia is a problem with the electrical signalling in the heart. So the heart is an incredible organ. It pumps blood around the body, and to do this it goes for a cardiac cycle which lasts, each cycle lasts about 0.8 seconds, okay, and in that cardiac cycle the atria contract first and then the ventricles contract after that. Now in order to coordinate that, the heart has incredible electrical signalling properties, okay, to make the correct parts of the heart contract at the correct times. If you get problems with the electrical signalling within the heart, that's going to lead to the wrong portions of the heart contracting at the wrong times, okay, and that is what a cardiac arrhythmia is, a problem with the electrical signalling in the heart, which then leads to a problem in the cardiac rhythm. It leads to a problem in the cardiac cycle. The heart no longer goes through the cardiac cycle correctly, and of course that's extremely dangerous because it's going to mean that blood is no longer potentially going to be pumped around the body in the correct way. So it's quite a logical name, arrhythmia, a problem with the cardiac rhythm. Okay, now, the first thing to say is that there is a movement that is not terribly successful to rename the topic of cardiac arrhythmias, okay, to the topic of cardiac dysrhythmias. So I'll just put this word here. Okay, so some people want to have the word arrhythmia scrapped and replaced with the word dysrhythmia. And the reason is that arrhythmia, if you actually look at the the structure, the linguistic structure of this word, it implies that the heart has actually stopped beating, that the rhythm has completely ceased. Whereas dysrhythmia, dys just means a problem with, so this really is a better word to use for meaning a problem with the cardiac rhythm. So generally what's happened is that biomedical scientists now use the word dysrhythmia, cardiac dysrhythmia, whereas the actual clinicians, who are very stubborn, still use the word arrhythmia. So if you're being taught by a biomedical scientist investigating dysrhythmias potentially, they will probably use the word dysrhythmia, whereas clinicians will use the word arrhythmia. So be aware that there are these two different terms. Dysrhythmia is probably the better candidate and may well eventually displace arrhythmia, but arrhythmia is the one that's still in most common use, which is why the entire video is entitled Cardiac Arrhythmias rather than Cardiac Dysrhythmias. Okay, but be aware that you can use either of those two terms and they mean the same thing, a problem with the cardiac rhythm, but as I say, there is a movement towards trying to get arrhythmia phased out as a word and to use dysrhythmia instead. Okay, so what we need to begin with then is we need to begin with a little recap of how the electrical signal propagates through the heart. I also want to have a recap of why that gives rise to the normal ECG pattern, okay, and then I want to have a little recap of what the sympathetic nervous system and parasympathetic nervous system stimulating the heart does. All of that basic physiology will be absolutely essential for us to then go on and discuss the arrhythmias. What we will then do is we'll work through the arrhythmias in what I think is a reasonably logical order, okay? But the problem with arrhythmias is that it's an enormous topic and that it's quite difficult to organise it into a series that makes sense, okay? Because often lots of the different arrhythmias, those are the different problems that can actually occur, they're completely different, okay? What's caused them is completely different. So it is a gargantuan, great big topic, and it is quite difficult to organise, so it will be a bit listy. We will just be going from one arrhythmia to the next, to the next, to the next. But as I say, it's an absolutely essential topic to understand, so if you do follow this video all the way through, you will have really put yourself in a good position for going into clinical medicine. Okay, right, so we're going to begin then with physiology, and I'll try to keep this as recap rather than as teaching for the first time so that we get through it quickly. If you aren't familiar with this stuff, then you should really go back and watch previous videos in the playlist on the cardiovascular system. I have a video entitled The Cardiac Cycle and Cardiac Electrophysiology, where we go through the electrical signals in the heart in much more detail than we will here. In addition, I have a video entitled The Electrocardiogram, where we discuss why the electrocardiogram looks like it does in a lot more detail. Here I'm just going to give a recap. Okay, so let's begin with this physiology. So, firstly, I want to talk about how the electrical signal is propagated through the heart. So I'll start by drawing a picture of the heart, and we'll take this cross-section through the heart. So the picture I'll draw is a cross-section through the heart. So you've taken a plane through the heart, and it's a bizarre sort of plane. It's a slanted plane that's sort of, if you're looking at someone's body from the front, so let's say the piece of paper is someone's body from the front. We've got a man sitting in the plane of the piece of, well, not sitting, but standing in the plane of paper here. Okay, then it's sort of at this sort of angle that my hand's making now, so you sort of cut through the heart so that you can see all four chambers. Okay, so what we'll see is something like this, and we can also see the heart muscle walls in between the four different chambers. So here, these two chambers up here are going to be the atria, and then down here we'll have the ventricles. Okay, like so. So of course we have the right atrium up here, so I'll label that up as RA. We have the left atrium up here, we have the right ventricle down here, and the left ventricle down here. Okay, so that's my simple picture of the heart, and I'm going to illustrate the electrical conduction system on this picture here. So where does the electrical signal that's going to cause the entire heart to beat actually arise from? Well, it arises from the sinoatrial node, which is up in the right atrium, near where the superior vena cava enters the right atrium. So let's have this little portion here, coloured in orange, and that little bundle of cardiomyocytes there, or little cluster of cardiomyocytes is probably a better word. This is called the sinoatrial node, or SAN for short. So this is a special cluster of cells that have incredible properties, and they have the incredible property that they will generate an action potential every 0.8 seconds or thereabouts. So we'll be working with the normal with the assumption that the normal cycle duration for the cardiac cycle is approximately 0.8 seconds. So I'll just write that number down. So this gives rise to a heart rate of 75 beats per minute. So if you just divide 60 by 0.8, you get 75. Okay, right, so the sinoatrial node is this cluster of cardiomyocytes which generate action potentials at a rate of 75 per minute. Right, now what's going to happen is those action potentials are going to spread to surrounding cardiomyocytes, so to the cardiomyocytes of the right atrium here. Now, cardiomyocytes, normal contractile cardiomyocytes, are capable of conducting the action potential to the next ones along. So the action potential can just propagate through the normal contractile cardiomyocytes. Despite that, there are specialized conduction pathways, or at least most people believe there are specialized atrial conduction pathways, three which pass the signal down to the atrioventricular node, and one which passes it onto the left atrium. Okay, so firstly let me just add on the atrioventricular node before I draw on the conduction pathways. So the atrioventricular node, remember, is this one little window in the atrioventricular septum. So remember, the atria of the heart and the ventricles of the heart, they are electrically insulated from one another, so the electrical signal cannot propagate from the atria to the ventricles. Okay, there is electrical insulation separating the atria and the ventricles, which I'll denote by this green line here. So these atrial cardiomyocytes cannot pass the action potential onto the ventricular cardiomyocytes. There is this electrical insulation. There is one window through this whereby the electrical signal can be conducted down to the ventricles, and that is of course known as the atrioventricular node, which I'll just abbreviate to AVN here. Okay, so what needs to happen is the electrical signal from the sinoatrial node needs to get down to the atrioventricular node. Now, it is still a little bit controversial, though most people now believe that there are conduction pathways, special conduction pathways to take the action potential from the sinoatrial node to the atrioventricular node. Other people, the people who don't believe that, just think that it propagates through the cardiomyocytes and then the cardiomyocytes conduct it to the atrioventricular node cardiomyocytes, i.e. you don't need specialised conduction pathways. Okay, but I will draw on the specialised conduction pathways because most people, as I say, do now believe in them. Okay, so we think there are 3 internodal conduction pathways, one that's anterior, one that's in the middle like so, and then one that's posterior and will go through the wall behind. Okay, so those are the internodal conduction pathways, and then we will also have, well, people believe there is also a conduction pathway to take the action potential very quickly to the left atrial cardiomyocytes. And the benefit of these conduction systems over just letting the action potential conduct through the normal contractile cardiomyocytes is that they will conduct the action potential faster than the normal contractile cardiomyocytes. Okay, so as well as the internodal conduction pathways, we believe there is an interatrial conduction pathway here which takes it to the left atrium. And that's got the name of Bachmann's bundle. Okay, so this is called Bachmann's bundle, or you could call it the interatrial conduction pathway. Okay, so that's there in blue. Right, so these are the atrial conduction systems then. So what will happen, to summarise then, is the sinoatrial node will generate an action potential every 0.8 seconds, and it will of course pass this to the surrounding contractile cardiomyocytes, and those will conduct the action potential to the neighbouring cardiomyocytes. In addition, we have these special conduction systems, or at least most people believe we have these special conduction systems, which pass the action potential very quickly from the sinoatrial node to the atrioventricular node down here. That's in the case of the, as I say, internodal conduction pathways. So these are the internodal conduction pathways, an anterior, a middle, and a posterior one. And we also believe that we have an interatrial conduction pathway known as Bachmann's bundle, which passes the action potential to the left atrial cardiomyocytes, and then of course we'll just release it on the left atrium and it will conduct down the left atrium. Now of course, as the action potential conducts from the contractile cardiomyocytes to the next contractile cardiomyocytes, those cardiomyocytes will be induced to contract, so this will cause the atria to contract. And of course they will push a little bit of blood down into the right ventricle and the left ventricle for the right atrium will push it into the right ventricle and the left atrium will push it into the left ventricle. Now remember, they only push a little bit of blood. They're not really that important, the atria, because the ventricle's already very full. When they were relaxing, they were getting blood coming back into them straight through from the atria into the ventricles. So of course we have the inferior and superior vena cava pushing blood into the right atrium, and it was just coming straight through into the right ventricle. And the same on the other side, the left side. The pulmonary veins were pushing blood into the left atrium, and it was just coming straight through into the left ventricle. So these were already quite full, but now when the atria contract, that's just going to add a little bit more blood into those chambers. Okay, right. Now what's going to happen is the electrical signal is going to be unleashed on the ventricles. So it's going to go from the atrioventricular node and it's going to be unleashed on the ventricles here. Now, we don't just want to unleash it at the top here, we want to unleash it at the bottom because we don't want the ventricles to contract from the top downwards, because that would end up pushing blood downwards, and we want to push blood upwards. Remember, the pulmonary trunk in the case of the right ventricle and the aorta in the case of the left ventricle are up here. We want to push the blood up and out, so we need contraction to begin at the bottom and spread upwards. Okay, so what we have is a ventricular conduction system which is designed to take the electrical signal to the bottom of the walls of the ventricles and then unleash it from the bottom upwards. Okay, so what colour shall I do the ventricular conduction system in? I think I'll go for orange. Go back to orange. Actually, orange probably won't show up as well as pink, so we'll go for pink. So Firstly, note that the atrioventricular node is quite slow conduction. Okay, the electrical signal propagates through the atrioventricular node reasonably slowly, and that's to give the atria time to actually contract and push blood into the ventricles before the ventricles contract, because obviously the atria would have a very difficult time pushing blood into the ventricles if they were contracting. They'd fail because the ventricles have got much more force in them. Okay, so you want to wait a little bit before you actually have ventricular contraction, so the atrioventricular node introduces delay. Then what we have is a big bundle coming out of the atrioventricular node of cardiomyocytes that are specialized for conduction. So these are conduction cardiomyocytes rather than contractile cardiomyocytes. Okay, and this bundle is of course the bundle of His. Okay, now note that all of these ventricular conduction systems, these conduction cardiomyocytes that form these pathways in the walls of the ventricles, these are electrically insulated from the other cardiomyocytes, the contractile cardiomyocytes. It would not do for these cardiomyocytes to give the action potential to the surrounding contractile cardiomyocytes in the interventricular septum. Okay, so there's fibrous connective tissue insulating the conduction cardiomyocytes of the ventricular conduction system from the contractile cardiomyocytes of the walls of the ventricles. Okay, so this is the bundle of His initially, and then the bundle of His very quickly splits down into two separate branches, one for the right ventricle, which will have going round like this, and then one for the left ventricle, which will have going round like this, and these are known as the left and right bundle branch. So we have the right bundle branch, which is often just abbreviated to the RBB for short. Okay, so this is the RBB, right bundle branch, and then of course we'll also have the left bundle branch, and I'll just abbreviate that down to the left bundle branch, the LBB. Okay, right, so then what happens is that the bundle branches are going to give off smaller little fibres that are then going to pass the action potential to the contractile cardiomyocytes of the ventricular walls, and these smaller little conduction fibres are known as the Purkinje fibres. So I'll have these in green here. So off the bundle branches you're going to have lots of little conduction fibres here coming off, and these are now known as the Purkinje fibres. Okay, and they will pass the electrical signal, the action potential, onto the contractile cardiomyocytes. Okay, now it's important to understand the order in which the cardiomyocytes in the ventricular walls are actually going to contract. So what happens is the first bit of contractile cardiomyocyte tissue to actually get given the action potential is actually the interventricular septum here, and it's given it by Purkinje fibres of the left bundle branch here. So here, it's shown here in green. In fact, I'll have it in another colour. I'll have it in blue here so that it's more obvious. This is supposed to be a Purkinje fibre giving the action potential to these contractile cardiomyocytes in the interventricular septum. So yes, we've got the conduction cardiomyocytes in the interventricular septum, but we've also got a lot of contractile cardiomyocytes in the interventricular septum. And these are going to be given it from the bottom here. Okay, and now what's going to actually happen is the electrical signal is going to propagate up the interventricular septum in this direction, and that's important for interpreting the ECG pattern. Okay, right. So firstly, the action potential is unleashed on the interventricular cardiomyocytes then. Then what happens is the Purkinje fibres of the right bundle branch and left bundle branch release the action potential onto the major portion of the ventricular wall, and just like I've shown in this picture, they unleash it onto the very inner cardiomyocytes before the outer cardiomyocytes. Okay, so these bundle branches, they are on the inside of the ventricular wall. Well, not on the inside, I mean you wouldn't, if you were standing in the ventricles, be able to see them, but they're in the inner portion of the myocardial wall rather than the outer portion of the myocardial wall. Now the inner portion of the myocardium has a special name. This is known as the subendocardial myocardium. Okay, and the reason for it being called that is the endocardium. The meaning of endocardium is the equivalent of endothelial cells but in the heart. So you know that all of the blood vessels of the body are lined by endothelial cells. The heart is part of the circulatory system. It's also lined by endothelial cells. So inside of the myocardial wall, you have endothelial cells. These are known as the endocardium. So subendocardial means underneath the endocardium, myocardium, okay, which just means muscle of the heart. So it means the inner portion of myocardium. So this is the fancy way of saying the inner myocardium. Okay, so the inner myocardium is going to be given the action potential first, and it's going to propagate outwards like so to the outer portion of the myocardium, and there is a proper fancy name for the outer portion of the myocardium as well. It's known as the subepicardial myocardium. Okay, so the epicardium is a layer of cells on the outside of the heart. So subepicardial means underneath the epicardium. Okay, so that's where that word comes from. So it's the fancy way of saying the outer portion of myocardium. So the action potential is released onto the subendocardial myocardium before the subepicardial, and it propagates from the subendocardial contractile cardiomyocytes out to the subepicardial cardiomyocytes. And as I say, this is really important for ECG interpretation. Okay, then what happens is up here, you can see that the bundle branches don't extend all the way out. So the final bit of the ventricles to be given the electrical signal is these posterior portions over here, the posterior portions of the ventricles. So what's now going to happen is they're going to finally get the electrical signal released onto them, and of course the way that the electrical signal will pass is it will propagate up and backwards in this direction here. Okay, and that's the final portion of the ventricle to actually be given the electrical signal. Okay, now one final thing to tell you about, actually let's just finish the story. So now what will happen is the ventricles will contract when of course they receive the electrical signal. So the ventricular cardiomyocytes will contract once they receive the electrical signal, and this will cause ventricular contraction, and the blood will be expelled into the pulmonary trunk in the case of the right ventricle and the aorta in the case of the left ventricle. Excellent. So one further thing that I need to tell you about in order for us to now talk about ECG interpretation is repolarization. Okay, now atrial repolarization doesn't actually matter as far as the ECG is concerned. You can't actually see it on the ECG, so we won't talk about atrial repolarization, but ventricular repolarization, that's the T wave in the ECG. So we do need to talk about the order in which repolarization occurs. So the cardiac action potential, you have the upstroke of the action potential, you then have the plateau phase, and then you have the downstroke, the repolarization phase. Now, which portions of the ventricles would you expect to repolarize first? Well, let's just talk about the major portions of the ventricles. Let's ignore the interventricular septum and the posterior portions. Let's just talk about these major portions, because this is the portion that you're actually going to see on the ECG. Okay? The electrical signal arrived first at the subendocardial, the inner myocardium, and then propagated out to the outer myocardium. So you would expect the inner myocardium, the subendocardial myocardium, to repolarize first, and then the subepicardial myocardium to repolarize last. That is not the way it actually occurs. The subepicardial myocardium repolarizes first. The action potentials of the subepicardial myocardium are shorter than the action potentials of the subendocardial myocardium. So in fact, what actually happens is the subepicardial myocardium, even though it received the electrical signal after the subendocardial myocardium, it finishes its electrical signal, it finishes its action potential first and undergoes repolarization first. So repolarization actually propagates from the outer portion of the myocardium inwards, and that's really important for understanding the ECG. Okay, so now that we've gone over the electrical conduction system, let's now talk about the electrocardiogram, the ECG. Okay, so we're going to talk about the classical electrocardiogram. So, you know, the trace that you are used to seeing, you know, the famous one. Now, when you actually do an electrocardiogram in the clinical setting, you actually do 12 different ones. You do what's known as the 12-lead ECG, where you are looking at the electrical potential difference between those of different points all over the body, and some of those look very different to the classical one that everyone's used to seeing. For instance, some of them will be inverted, or they might have less extreme versions of each of the waves. However, what we will do for the purposes of this entire video is we'll just talk about the classical one, and the classical one on the 12-lead ECG is lead 2. So lead 2 of the 12 leads of the ECG is the one that looks like the classical ECG that everyone's used to seeing. Okay, right. So what do you actually do when you're taking an ECG? Well, we'll talk about lead 2 of the ECG. What you actually do is, if this is your person here, okay, you attach 2 electrodes to do lead 2. You put 1 electrode onto the right arm up here, so this is the right arm. RA is now standing for right arm rather than right ventricle. And you attach another electrode onto the left leg down here. Okay, so 2 electrodes onto 2 of the limbs, like so. And then what you're actually going to do is you're going to follow the electrical potential difference from the right atrium to the left. Sorry, I've already made the mistake that I just warned you against. From the right arm to the left leg. So you are going to be looking at what is the electrical potential difference from the right arm up down to the left leg, and you're going to plot a graph of that against time. So you're going to put 1 electrode on the right arm, 1 electrode on the left leg. You are going to measure the difference in electrical potential between these 2 points, i.e. if you were to move from the right arm to the left leg, what is the difference in electrical potential that you go through? Okay, now, why is there going to be an electrical potential difference between these 2 points? Well, if you got rid of the heart, there wouldn't be. But because of the heart, because of the electrical activity in the heart, what's actually going to happen is, as the cardiac cycle goes through its recurrent cycles, the electrical potential at these 2 points is going to vary at different points of the cardiac cycle, and therefore you're going to notice electrical potential differences actually being formed, being produced between these 2 areas. Okay, so what you will end up with then is a classical ECG trace that looks like this. Here is the first P wave, here is the portion following the P wave, then you'll have the QRS complex here, then the ST segment, and then the T wave here, and then it will end here. Okay, so what I want to talk about is why, well, just give you a brief reminder of why it actually looks like this. So this portion, the initial portion here, is known as the P wave. So let's firstly talk about why you get the P wave here. Okay, so the P wave represents atrial depolarization. So we're starting from the beginning of the cardiac cycle. So this is what the electrical potential difference between the 2 points would have been just before the sinoatrial node begins to actually fire out electrical signals. Okay, and that electrical potential difference between the 2 would have been 0. So here, this is actually called the isoelectric line, when the 2 points where the 2 electrodes are have the exact same electrical potential, so there is no electrical potential difference between the 2. So here the answer is actually 0, the voltage between the 2 is 0. Okay, now when the sinoatrial node sends out action potentials, what's actually going to happen is, because the electrical signal is propagating through the atria, it's actually going to change the electrical potential at these 2 points. Why is it going to change the electrical potential at those 2 points? Well, remember, when cardiomyocytes pass the electrical signal onto then the next cardiomyocyte along, so let me just draw a little picture here. So here's one cardiomyocyte, and here's the next cardiomyocyte along, and let's say this cardiomyocyte wants to excite this one. Well, what actually happens is there are gap junctions between the 2 cardiomyocytes. So this is meant to represent a gap junction, and this is an electrical synapse between the 2. And this allows positively charged ions to move from the one cardiomyocyte to the next. Now let's say cardiomyocyte number 1 here has undergone an action potential. Now in the upstroke of the action potential, the electrical potential inside the cell rises hugely, okay, because there are sodium ions coming into the cell in the case of a normal cardiomyocyte. Okay, of course, in the case of the sinoatrial node cell, it's slightly more complicated because the upstroke of the action potential is caused by calcium rather than sodium. But in either case, there is a rise in the electrical potential intracellularly. This one hasn't yet undergone an action potential, so its electrical potential intracellularly will still be the same. So that means that now there is an electrical potential difference between the intracellular compartments here, and that will drive the movement of positive charge from the one that has already undergone the action potential to the one that has not. So you have a current, basically, from the cardiomyocyte that is passing the electrical signal on to the cardiomyocyte that is receiving the electrical potential. Now, think about this. All over the atria, as the electrical signal propagates in this direction, you are getting currents like this going through the cells, or occurring within the cells here. So that must sum up to an actual noticeable effect, or indeed does sum up to a noticeable effect. All over the atria, you are getting little currents moving in this direction, in the direction that the electrical signal is propagating. So going back to the entire body now, we have actually got movement of positive charge in this direction overall. It's happening at the heart, but the effects of moving electrical charge are going to be felt all over the body. Okay, tiny little effects, yes, but you will still feel the effects. So we're moving positive charge away from the right arm and down towards the left leg overall. So we're going to be raising the electrical potential at the left leg, and we're going to be lowering the electrical potential at the right arm. So now, if we ask what's going to be the electrical potential difference from here to here, I've said that the electrical potential here is going to be going up, here it's going to be going down. Initially they were both equal, okay, so initially it was like this. Here was the electrical potential for the right arm, and here was the electrical potential for the left leg. But now this one's gone down because we're moving positive charge away from there, and this one's gone up because we're moving positive charge towards there. So obviously that's going to create an electrical potential difference, a positive electrical potential difference, which is why the P wave deflects up in this way. Okay, this is showing us the electrical potential difference from the right arm to the left leg. Okay, so that's why you get this deflection upwards. Why does it then come down? Well, once the atria have actually contracted and the electrical signal has propagated through the entire atria, then this intracellular current stops. Now, when you have an electrical potential difference between 2 points, that is incredibly unstable because electrical potential differences make charged particles move. Okay, so having this electrical potential difference between these 2 points will drive a current to move in the opposite direction. Electrical potential differences can only exist for a transient amount of time before charged particles will move to get rid of them. So if we have this electrical potential difference between these 2 points, obviously that will drive positive charge to move in the opposite direction. So yes, you create this transiently whilst the atria is actually undergoing this process and moving the positive charge from cardiomyocyte to cardiomyocyte, and overall it's all in this downward direction in this way. But very quickly after you've created this, you'll get positive charge all over the body moving in the opposite direction to return the electrical potential difference between these 2 points back to zero. So that's why the P wave does come back down, why it's only a temporary deflection upwards. So the electrical potential difference that you get from the right arm to the left leg is only going to be there transiently, because they're just not stable. As soon as you create an electrical potential difference, current will move between those 2 points to get rid of it, basically. Okay, and that's why it comes back down again. Right, so the P wave represents atrial depolarization then. Let's now talk about this next portion of the electrocardiogram. And by the way, this entire portion here from the P wave, including this blue portion, this has a name. This is known as the PR interval. And the reason it's called the PR interval, and I'm just going to check that this is visible, yep it is because this fancy thing that we've got here, which we haven't studied yet, this is called the QRS Complex, okay, and the R portion is the main portion in the middle, so that's the main portion of the QRS Complex. So the PR interval is the portion from the P wave up to the beginning of the QRS Complex, is the reason that this is called that. Okay, right. So this portion in between where the electrical potential difference just remains the same, that's where the electrical signal, the action potential, is propagating through the AV node and through the His, the bundle of His and the bundle branches as well. So when it's propagating through the ventricular conduction system, or the atrioventricular conduction system, but it hasn't actually been released on ventricular cardiomyocytes yet, that's what's happening here. And the reason you don't see any change in the electrical potential difference across the, between the right arm and the left leg, is because although there is going to be current moving from cardiomyocyte to the next cardiomyocyte in these conduction systems, they are so small, there's very few cells in these compared to the number of cells that are actually in the contractile portions of the myocardial walls, that you're not actually going to get a big enough current propagating in this direction in order for it to cause a noticeable electrical potential difference from the right arm to the left leg. So that's why this portion remains flat. Now let's talk about the QRS complex, because this is when it starts being released on the actual ventricles. The QRS complex, this now represents ventricular depolarization. So the first deflection downwards is called the Q wave, the middle deflection upwards is called the R wave, and the final deflection downwards is called the S wave. So this is the QRS complex, consisting of these three waves, the Q wave, the R wave, and the S wave. Okay, so why does it have this form? Well, it's just these arrows here. This is why I stress this when we're actually going through the conduction of the electrical signal, because it explains the QRS complex. So remember, when the electrical signal, the action potential, is released onto the ventricular cardiomyocytes, the first portion that gets the electrical signal released onto it is the ventricular septum here, by the left bundle branch. So the left bundle branch has Purkinje fibers coming off it, which will stimulate the interventricular septum. And look, the way that the action potential spreads up the interventricular septum is in the opposite direction to the way that the electrical signal propagated down the atria. So now what's going to happen is you're going to get, again, one of these currents being established in the opposite direction. And by the way, these currents, they have names. They are called cardiac vectors. So the cardiac vector, this is a really important concept when interpreting ECGs. It represents the direction in which the electrical signal is propagating, and in particular it represents the direction in which this intracellular current is moving. Okay, so the cardiac vector is now going in the opposite direction, so now overall what you'll be doing is moving current in the opposite direction now, away from the left leg up to the right arm here. So you'll be bringing positive charge up towards the right arm and away from the left leg. So you'll be raising the electrical potential up at the right arm and lowering it down at the left leg. So this will go up, this will go down. You'll now get a negative electrical potential difference from the right arm to the left leg, which is why it deflects downwards here. Okay, then as you can see, it very quickly goes in the opposite direction into this R wave here. That's when the electrical signal is released onto the major portions of the ventricles. And look, it starts at the subendocardial myocardium and propagates down to the subepicardial myocardium. So again, you can see that the overall direction in which we are going to get this intracellular current moving is down in this direction. The cardiac vector is in the same direction as it was for atrial depolarization. So that's why we again get a massive deflection upwards. Okay, and of course again it's going to come back down because electrical potential differences are unstable. You will get current, extracellular current, ions moving in the opposite direction to re-establish electrical equilibrium. And then finally the S wave is when the Purkinje fibers finally release the electrical potential onto the posterior portions of the ventricular wall here, and then it will propagate backwards, and again the cardiac vector will be pointing in that opposite direction, and therefore we'll get a downward deflection again. Okay, and again it's transient because as soon as you've created this electrical potential difference between the 2 points, you'll then get extracellular current moving in the opposite direction to destroy it, to return us back to the isoelectric line, electrical equilibrium. Okay, after the QRS complex, we then have the ST segment, and this represents where the ventricular cardiomyocytes are actually contracting whilst their action potentials are in the plateau phase. Okay, so no propagation of intracellular current at this point. Then what we've got here is the T wave. Now this requires a new concept. This represents this represents ventricular repolarization. Okay, now in ventricular repolarization, the electrical potential difference across the cell membrane goes back to being what it was before. Now, if you've got a cell repolarizing, the intracellular electrical potential is going to be dropping back down. So let me draw another one of these pictures here to try and explain this. So again, let's have two cardiomyocytes here, okay, and let's have them linked by a gap junction here. Okay, now let's say this one here, number 1, is repolarizing now, and the one that's next to it, 2 here, is not yet repolarizing. It's still in the plateau phase. So this one's repolarizing before this one, so the wave of repolarization is going to propagate in this direction. Okay, when this one repolarizes, the electrical potential intracellularly is going to drop back down to what it should have been, what it is at rest, whereas the electrical potential intracellularly here is still elevated. So now you're going to get positive charge moving in the opposite direction, because positive charge will always move to the area of lower electrical potential. Okay, so for repolarization you get a positive current moving into the cells that are repolarizing, whereas for depolarization you get the positive charge moving out of the cells that are depolarizing. Okay, now, how did I tell you repolarization occurs? It starts in the subepicardial myocardium, and this is a really important fact just to remember. It starts in the subepicardial myocardium and then propagates, the wave of repolarization propagates inwards. That means that you're going to get positive charge moving outwards, because positive charge, this positive intracellular current, moves from the cell that has not repolarized yet to the one that has repolarized yet. We start repolarizing on the outside, therefore the cardiomyocytes that are inwards from those cardiomyocytes on the outside are going to be passing positive charge out to those. So indeed, for repolarization, the cardiac vector, the direction of intracellular current flow, is again going to be downwards. Hence we're going to get a deflection upwards here. So the T wave here is ventricular repolarization, and again it goes up as we're moving intracellular current this way, and then you transiently establish it, and then of course it will be destroyed by extracellular current moving to destroy this electrical potential difference across the cell membrane, and you'll return back to the isoelectric line where you have no electrical potential difference between the two areas. So, there is the classical ECG and the explanation for the classical ECG in terms of the way in which the electrical signal propagates through the heart. So we're almost done with our recap of physiology. All that I want to finish with now is to remind you of what the sympathetic nervous system does to the heart and what the parasympathetic nervous system does to the heart. So they're complete opposites. Okay, so remember, the sympathetic nervous system is going to be activated in times of stress, fight and flight. Okay, so when you're stressed, the sympathetic nervous system is going to be activated. Now, the sympathetic nervous system, you have a lot of sympathetic nerves that are going to release the hormone, or the neurotransmitter rather than hormone. They're going to release the neurotransmitter noradrenaline all over the heart. So you've got sympathetic nerves that will synapse all over the heart and release noradrenaline all over the heart. So the entire heart, all of the cardiomyocytes all over the heart are going to be drenched in noradrenaline. Okay, also in the States known as norepinephrine. Okay, so both of those names are fine, so I'll just add the nor on as well. So norepinephrine or noradrenaline. Okay, so noradrenaline or norepinephrine is then going to act on beta-1 receptors on the cardiomyocytes. So cardiomyocytes have a specific receptor for noradrenaline, which is the beta-1 receptor, which is a G protein coupled receptor. So it's going to have the 7 membranes spanning alpha helices like so. So this is the cell membrane. Here is my G protein coupled receptor sitting in the cell membrane. Now, I am not going to go through the intracellular signaling cascade downstream of the beta-1 adrenoreceptor. It's not really necessary for our discussion. I'm just going to discuss what's actually happening on the cellular level rather than on the molecular level. It does work through the GS cascade, but as I say, we're not going to go there. We're just going to do it on the cellular level. So for our purposes, the cardiomyocytes have beta-1 adrenoreceptors on their surfaces. Noradrenaline or norepinephrine is going to bind to these beta-1 adrenoreceptors and will trigger an effect within the cell. We are not going to go into the intracellular signaling cascades to understand exactly how the binding of the drug to the receptor then triggers the effect. We're just going to go straight to effect. So what are the effects that this actually has? Well, it has lots of effects. It increases chronotropy, inotropy, and dromotropy. And overall what this is going to do is it's going to increase heart rate and also increase cardiac contractility. So, firstly, beta-1 receptors on the sinoatrial node cardiomyocytes, they are going to make the sinoatrial node cardiomyocytes fire off electrical signals at a higher rate. Okay, now the name for this is a positive chronotropic effect. So chronotropy refers to the rate at which the sinoatrial node cells are actually generating electrical signals. So we would say that because noradrenaline or norepinephrine acting through the beta-1 adrenoreceptor is going to raise the rate at which sinoatrial node cells fire electrical signals, we would say it has a positive chronotropic effect. Okay, so I'm just going to write chronotropy goes up. So the rate at which the sinoatrial node cells fire action potentials is going to go up. Okay. In addition, there is very little point in raising the rate at which the sinoatrial node cells fire action potentials if you don't also raise the rate at which the atrioventricular node cells conduct the action potentials. Because remember, the atrioventricular node, it's very slow. It conducts action potentials very, very slowly. Okay, so if you actually want to raise heart rate, then you want the frequency at which electrical signals will propagate to be raised. Okay, so you need to also raise the rate at which the electrical signal will pass through the atrioventricular node. And there is a word for this, dromotropy. So dromotropy refers to the rate at which the electrical signal will actually pass through the atrioventricular node. So beta-1 receptors on the AV node conduction cells will speed up the rate at which the AV node cells will pass the action potential through, so that actually raising the rate of the sinoatrial node firing will result in an increase in the rate at which you get action potentials propagating down to the ventricles. If you didn't do this, then what you'd end up with achieving is the sinoatrial node cells would be firing action potentials off at a much rapider rate. Let's say it's increased by a factor of 2. So the sinoatrial node cells are firing action potentials off at twice the normal rate, but the atrioventricular node cells would not be conducting all of those down to the ventricles. It might be conducting every other one, so that the actual rate of ventricular contraction is the same. The atria would then be contracting twice as often as the ventricles. Okay, so you do need to have an effect on the atrioventricular node to tell it to let all of these action potentials that the sinoatrial node is sending to it actually go through. Okay, so dromotropy is going to go up as well, so that the AV node actually conducts all of these electrical signals down to the ventricles, actually increases the number of electrical signals that it's going to propagate down to the ventricles. Okay, and the final thing that actually occurs refers to all the contractile cardiomyocytes. So all of the contractile cardiomyocytes will also have beta-1 adrenoreceptors on them. And when noradrenaline or norepinephrine binds there, it will trigger them to contract harder whenever they get an electrical signal. So the amount of force they will actually generate when they contract is actually going to increase. And that's known as a positive inotropic effect. So inotropy refers to how hard the contraction cardiomyocytes actually contract when they receive an electrical signal. So beta-1 adrenoreceptors, when stimulated, have a positive inotropic effect. So the sympathetic nervous system increases chronotropy and dromotropy, so that the heart will actually undergo cardiac cycles at a faster rate, more than 75 beats per minute, and it also actually works on the contractile cardiomyocytes to make sure that when they actually contract, they're going to contract with greater force. And this overall hugely increases cardiac output. Now, why is that beneficial in a stressful situation? Well, if you're going to have to fight or flight, you're going to need a lot of blood going to your skeletal muscle cells, and therefore you're going to require a larger cardiac output. And the parasympathetic nervous system does the exact opposite. So you have parasympathetic nervous system neurons, again synapsing all over the heart, and they release the neurotransmitter acetylcholine. Acetylcholine again acts on a G protein coupled receptor on cardiomyocytes. This time it's called the M2 receptor, the muscarinic acetylcholine receptor 2. Okay, and again it looks exactly like this for a simple picture. So it's a 7 transmembrane receptor. Okay, so again we won't go into the intracellular mechanisms, we will just do this on the cellular level. So acetylcholine will bind to M2 receptors on cardiomyocytes, and what's it going to trigger? The opposite of all of these effects. On the sinoatrial node cells, the binding of acetylcholine to M2 receptors will trigger them to release action potentials at a lower rate, so it will trigger a negative chronotropic effect. It will also cause the atrioventricular node cells to conduct action potentials at a lower rate. Okay, so it'll cause a negative dromotropic effect. And finally, on the actual cardiomyocytes themselves, it will cause a negative, the contractile cardiomyocytes themselves, it will cause a negative inotropic effect. It will make those cardiomyocytes contract less hard whenever they actually get an electrical signal. And this, of course, preserves energy. It means that the heart will use less energy, and it's what you would be doing if you're in a very relaxed situation. So the parasympathetic nervous system is the rest and digest circumstance system to be activated. So if you're very, very relaxed, if you're not doing anything, you don't require a very high cardiac output, then the parasympathetic nervous system will dominate, and it will keep your heart rate at a nice, slow, relaxed level to conserve energy, because there's no point having a huge cardiac output if it's not necessary. Let's conserve energy. So that's the effect of the sympathetic nervous system and the parasympathetic nervous system on a cellular level. Okay, we haven't been through the intracellular signaling pathways because they would take a long time to go through, and they're not necessary for our discussion. Okay, so we'll have a break there, and in the next video what we'll do is we'll start actually talking about the arrhythmias.